So, to test your knowledge before you look at any of the videos of what the latest guidance is, we've got a few quick case studies or questions. We'll move on to the first question. So, you are in practice and conducting Mrs. Jones's annual review. She has a past medical history of hypertension, osteoarthritis, obesity, and underwent a coronary artery bypass graft procedure in 2005. What target cholesterol, an LDLC or non-HDLC, should you recommend Mrs. Jones aims for? Is it A, an LDLC of less than 1.8, B, a non-HDLC of less than 5, total cholesterol of less than 4, or a non-HDLC of less than 1.8? I'll give you a few seconds to pick one. And the answer is, of course, an LDLC of less than 1.8 or a non-HDLC of less than 2.5. An LDLC of less than 1.8 is roughly equivalent to a non-HDLC of 2.5, and that's why we have the two numbers there, both essentially referring to LDLC or an estimation of LDLC. So why is the recommended LDLC target for secondary prevention less than 1.8 millimoles per litre? Is it A, because of cost of statins, B, to reduce the risk of CKD, C, below this threshold, plaque progression will be stopped, or D, because our health minister said so? And the answer is, of course, C. This is why latest evidence guidelines across the world are moving to an absolute LDLC target as opposed to a percent reduction in cholesterol. At below 1.8 millimoles per litre of LDLC, progression of atherosclerosis is halted. And that's why it's so important that we aim for this target within our very high risk patients. So Tim has just been discharged from hospital after suffering from a heart attack. He's currently undergoing cardiac rehab. Which statin and at what dose would you expect him to be on? Is it A, rosuvastatin 10 milligrams, atorvastatin 80 milligrams, simvastatin 80 milligrams, or fluvastatin 20 milligrams? The answer is, of course, atorvastatin 80 milligrams, which is the recommended first-line high-intensity statins that would usually be straight after someone has a stroke or heart attack. The recommendations in our new guideline mention they talk about high-intensity statins, and technically a high-intensity statin is one that would lead to a greater than 40% reduction in your cholesterol. Out of these choices, rosuvastatin 10 milligrams is indeed a high-intensity statin and dose, and would roughly lead to about a 43% reduction in atorvastatin 80 milligrams gives about a 55. Simvastatin 80 milligrams is also a high intensity statin, however, giving an average reduction of about 42% in LDL cholesterol. And it's for this reason, as well as the side effect profiles, as to why atorvastatin 80 milligrams is our recommended statin and dose of choice from the majority of people. Which of the following groups of people should be offered a statin as part of primary prevention of CVD? Our options are patients with a Q risk of greater than 10%, type 1 diabetics and who are over the 40 years old, people with CKD and an EGFR of 67, EGFR of 45. The current guidelines recommend that everyone and with a Q risk greater than 10% are offered statin therapy, of which the recommended statin and dose is atorvastatin 20 milligrams. Type 2 diabetics with a Q risk of greater than 10% should also be offered atorvastatin 20 milligrams, as should type 1 diabetics if they are over the age of 40 or have had diabetes for more than 10 years or have established nephropathy. In terms of CKD, the answer here is D. Patients with CKD and an eGFR of less than 60 should be offered atorvastatin 20 milligrams once daily. Which statin and at what dose should you avoid prescribing due to its increased risk of causing muscle problems? So A, atorvastatin 80 milligrams, simvastatin 10 milligrams, rosuvastatin 40 milligrams, simvastatin 80 milligrams. Of course, the answer here is simvastatin 80 milligrams. Simvastatin 80 milligrams only gives a 42% reduction in LDL cholesterol, whereas it has a significantly increased risk of muscle toxicity, and that's why it's not recommended anymore. If patients are stable on simvastatin 80 milligrams and they're happy to continue taking it and they don't have any problems and they wish to continue, that's okay. However, it might be worth having an open discussion with patients about switching to atorvastatin, and especially those who are experiencing any problems with simvastatin. Hello, my name is Seem and I'm an academic GP and the CVD prevention lead for the Greater Manchester ICS. Over the past few months, I've come to see CVD as a huge problem and threat to the well-being of all of us and the people we see every day. While CVD has several underlying complexities and has always been a leading cause of death, there has been much going on in the past few years, and it's something I think we should be doing a lot better at with technologies, medicines, and people we already have. I'll be spending the next few minutes discussing CVD or cardiovascular disease, why it's so important in Greater Manchester, and why cholesterol and how we manage it could play a significant role in improving the lives of our population. First, some definitions. Cardiovascular disease, or CVD, is an umbrella term for many conditions that affect the heart or blood vessels, inclusive of things like hypertension and heart failure. You may also hear about ASCVD, which is CVD caused by AS, atherosclerosis, which is a buildup of cholesterol containing plaques, which leads to heart attacks, strokes, angina, and peripheral arterial disease. People with high cholesterol, high blood pressure, diabetes, and an irregular pulse, or AF, are at significantly increased risk of CVD events, and these are known as the high risk conditions. You might hear about the ABCs, which represent AF, blood pressure, and cholesterol. The NHS long term plan identifies CVDs as the single biggest area where we as the NHS can save lives over the next 10 years. This diagram shows the cause of death of everyone in Manchester in 2019 and clearly demonstrates the scale of the problem, accounting for about a third of all deaths in Greater Manchester. At this stage, this is unfortunately not just a primary care or secondary care problem, but a whole system issue, as signified by premature death rates rising for cardiovascular disease for the first time in 50 years. Since 2014/15, hospital admissions for all ages for coronary heart disease has generally been falling in GM following the national trend. However, GM saw an increase in coronary heart disease admissions in 2017/18 in contrast to England and our regional neighbours, and we continue to have a substantially higher rate than the rest of England. The same is unfortunately true for stroke admissions, with GM stroke admission rate, which is the graph in the middle here, being significantly higher than the other areas within our region, as well as England as a whole. This is really important as stroke is one of the leading causes of disability, significantly impacting a person's quality of life, while also accounting for a huge part of the pressure on social care and resultant effect on the economy. These are unfortunately just all pre-COVID trends. Over the last 2 years, the pandemic's devastating effect on the UK's health has resulted in the greatest reduction in life expectancy in the majority of our lifetimes, and the first time it's dropped since 1981 or World War II, depending on your source. COVID-19 has not only highlighted but exacerbated long-standing socioeconomic inequalities in the UK. Indeed, a map of child mortality from 1851 bears striking similarities to a map of COVID-19 mortality rates, which is also basically the same as a map of prevalence of CVD, all following socioeconomic gradients. Minority ethnic groups and people with cardiovascular disease and high-risk conditions such as obesity and hypertension contributed to over 75% of deaths from COVID-19 during 2019/20. Reducing the prevalence of CVDs and comorbidities is therefore in itself an important part of mitigating against the future adverse health impacts of living with COVID. Indeed, a map of child mortality from 1851 bears striking similarities to a map of COVID-19 mortality rates, which is also unfortunately basically the same as a map of prevalence of cardiovascular disease, or following socioeconomic gradients. Minority ethnic groups and people with cardiovascular disease and high-risk conditions such as obesity and hypertension contributed to over 75% of the deaths from COVID-19 during 2019/20. Thus, reducing the prevalence of cardiovascular diseases and comorbidities is therefore itself an important part of mitigating against the future adverse health impacts of living with COVID. If you sit on the tram in central Manchester and head outwards, the life expectancy will on average drop by 1 year for every 3 minutes, which is largely driven by CVD, with those in the most deprived proportion of our society 4 times more likely to die prematurely due to CVD. Deprivation is also not the only inequality relating to cardiovascular disease, with people from South Asian and Black ethnicities and those with mental health problems also significantly more likely to be impacted. Thus, tackling inequalities is synonymous with tackling cardiovascular disease and narrowing the gap in outcomes between different groups of people within our society. The good news is we know what needs to be done. Much of the ill health and many of the deaths associated with CVDs are preventable by modifying risk factors and the use of readily available evidence-based cost-effective interventions and treatments. There's unfortunately no magic bullet, but many relatively simple things we could and should be doing to protect the lives of our population. We ultimately all have an important role to play. While GM may have some of the worst CVD-related outcomes in England, with people dying early or becoming disabled, we also have significant opportunities for improvement. There's been several recent advances in our understanding of cholesterol and its pivotal role in progressing, worsening, and perpetuating cardiovascular disease. And the data tells me that with a slight change in clinical practice, I really do believe that we can make a huge, tangible difference, which I know is what we are all here to do. Biomedically speaking, the root cause is atherosclerosis. While hypertension and diabetes lead to stress on the blood vessel walls, it's cholesterol that is also needed to complete the trifecta. Accumulation normally starts in late adolescence into early adulthood, and by your 30s, most people will have established fatty streaks in their arteries. Over time and increased high cholesterol exposure, these continue to build in the vessel wall, eventually rupturing to block the blood supply to the heart or brain, ultimately leading to diminished quality of life, disability, and premature death. While some of us often think of atherosclerosis as permanent, progressive, and irreversible, the latest evidence shows otherwise. While the fatty streak will always remain, if you significantly lower cholesterol early, that is before the plaque ruptures, i.e., before a CVD event such as a heart attack or stroke, you can help delay progression by stabilizing and maybe even slightly reducing the size of the plaque. This reduces the risk of rupture over the long term, leading to significant benefits over a person's lifetime. This is why we really shouldn't forget primary prevention and the importance of intervening early for those at high risk of cardiovascular disease. What about the people who have already had a heart attack or stroke? Their risk is absolutely undeniable, and they've already had one event. While many of us know about the 40% non-HDL reduction target from previous NICE guidelines, how many of us practice this? Well, the good news is that cholesterol management is about to become a lot simpler for us, while simultaneously leading to improved patient outcomes. There have been a lot of recent developments in the field, and whilst you can see from this graph here that the lower the better, and for as long as possible, we now also know that below an LDL-C threshold of 1.8, which is roughly equivalent to a non-HDL-C threshold of 2.5, the progression of atherosclerosis is essentially halted. The link between reductions in LDL-C and reductions in CVD events has now been demonstrated across multiple studies, different treatments, various meta-analyses, randomized controlled trials, prospective studies, and even Mendelian genetic studies, and is now essentially irrefutable. Ultimately, the point is, it doesn't matter how you lower cholesterol or what you use, but for those at very high risk of CVD, we need to aim for an LDL-C of less than 1.8 or non-HDL less than 2.5. Furthermore, while on the surface this appears to relate strictly to medicines, not taking the medicines prescribed to you or non-concordance would also significantly impact on this and could be improved by behavioral interventions such as motivational interviewing, social prescribing, and health coaching, as well as medication. I want to ensure we don't fall into the either or mindset and instead focus on what each of us can and needs to do to lead to the change we are seeking. There is now national consensus on this new absolute target, and moving to LDL-C and non-HDL could also potentially be a part of next year's QOF. Regardless of QOF, it will be a new GM standard of care as part of the ICS's CVD prevention work. The data presented here is taken from the CVD Prevent National Audit and is available down to the practice level and across GM, covering a variety of CVD-related indicators. What this shows is that in March 2022, that on average and across Greater Manchester, we are only adequately controlling the lipids of 23% of the highest risk patients. That means 77% of people who have already had a stroke or heart attack have cholesterol levels likely to lead to another event. With each 1 millimole per liter reduction in LDL-C associated with the 22% relative reduction in major cardiovascular events, this alone could make a significant impact on our MI and stroke admission rate, freeing up social care and hospital beds, but more importantly, protecting the quality of life of the population.
So, my name's Dr. Anne-Marie Kelly. I'm a consultant chemical pathologist at Wythenshawe Hospital at Manchester Foundation Trust, and I've been involved in lipid clinics for many years. And I've also been involved in this group that has put together some education for GPs. So thank you all for listening. So the first slide is I'm going to talk through is what's in a lipid profile. So it is a little bit different because at Manchester Foundation Trust, so that's the hospitals, Manchester Royal Infirmary, Wythenshawe Hospital, and Trafford General and North Manchester, we're using direct LDL cholesterol, which I will explain in some detail later. But a standard serum lipid profile, and for the most part, we recommend a non-fasting, and we'll discuss later at the times when you do need to have a fasting lipid profile. And that profile consists of total cholesterol, HDL cholesterol, which is, as you know, a good form of cholesterol, serum triglycerides, and a direct LDL cholesterol. So across MFT, this is a measured and not a calculated parameter. and therefore doesn't require a fasting sample. So the parameters in the lipid profile that are calculated are the non-HDL cholesterol, which is just basically what it says on the tin. It's a total cholesterol taking away the LDL cholesterol. And that's been used more recently by NICE for targets for treatment. And then we've got LDL cholesterol. What we often say to our patients is the bad form of cholesterol. And this is a calculation commonly called the Friedewald calculation, which takes away HDL cholesterol, but also allows for the fact that there's some cholesterol in triglycerides. The problem with the Friedewald calculation is that we can't use it if the triglycerides are above 4.5 because the calculation is found to be invalid. It is also perhaps not as reliable when the triglycerides are above 2. And there is some caution in diabetes and metabolic syndrome where the LDL cholesterol may underestimate the risk. And finally, we give you the cholesterol to HDL ratio, which is mainly used in primary prevention and entered into your Q risk scores. So what should you be measuring? Well, baseline is a full lipid profile. So total cholesterol, triglycerides, and HDL are the measured parameters in the lab, but it will also report an LDL cholesterol, non-HDL cholesterol, and a ratio from those parameters. And it can be useful because, particularly at the beginning, can indicate uncommon or genetic dyslipidemias, which need either further investigation or onward referral. And there's no need to fast, and we only suggest that you repeat the full lipid profile fasting if the triglycerides are above 2 millimoles per litre. You can do follow-up requests with cholesterol and HDL, but this isn't necessary if you're in an MFT lab. And the full lipid profile is used for patients with mixed hyperlipidemia who've got elevated triglycerides. And essentially, you need to do it when you've got patients with cardiovascular disease, a non-HDL cholesterol, which is non-ideal, i.e. above 2.5, and that is despite optimized statin and ezetimibe. And that is because LDL cholesterol is still used for deciding some of the other treatment options, which we're going to discuss later. What are the targets for lipid lowering? So for primary prevention, which isn't the main focus of our talk today, we're talking about a 40% reduction in non-HDL cholesterol. For familial hypercholesterolemia, it's a 50% reduction from baseline, so pre-treatment, in either non-HDL or LDL cholesterol. For secondary prevention, so that's anybody who's got clinical or imaging evidence of vascular disease, we're using the guidelines from the European guidelines from EAS and ESC, and that is a non-HDL cholesterol of less than 2.5, which is approximately equivalent to an LDL cholesterol of less than 1.8. The EAS guidelines also give targets for patients who have very high risk of cardiovascular disease. So those are patients who've had 2 or more events, or they've got disease in 2 different vascular beds, such as coronary artery disease and peripheral vascular disease. And a very high risk group where we're aiming for the lowest LDL cholesterol in patients who've had multiple recurrent events or progressive disease. Why is LDL cholesterol used for thresholds instead of non-HDL cholesterol? Well, non-HDL cholesterol is calculated, LDL cholesterol should be measured. But however, for the general population, there is good correlation between calculated LDL cholesterol and direct LDL cholesterol.
So in this short video, I'll be covering our new Greater Manchester secondary prevention lipid pathway. as well as some of the new case finding EMIS and System 1 searches that we've created. Back in December 2021, the Accelerated Access Collaborative released in conjunction with NHS England and NICE a new secondary prevention pathway for the management of patients at high risk of cardiovascular disease in terms of their lipid lowering therapy and their cholesterol targets. Without further ado, I'm pleased to present our new Greater Manchester Lipid Management Pathway for the secondary prevention of cardiovascular disease. It is available on the GMMG's website, and I know it can initially looks like there's a lot there, but the ultimate and most important message is that we need to now aim for an absolute LDL cholesterol less than 1.8, which is equivalent to a non-HDL cholesterol of less than 2.5. And this is because below these levels, progression of atherosclerosis is halted. Therefore, people at very high risk, people who have already had a stroke, a heart attack, it's even more important that their LDL is below 1.8. So this pathway is specifically for uh, people who have already had an event or people with angina or peripheral arterial disease. Uh, Again, the target, as I said, the target lipids are an LDL cholesterol of less than 1.8 or a non-HDLC less than 2.5. So if you start someone on torvastatin 80 milligrams, you repeat their cholesterol in 3 months, and their LDL cholesterol is less than 1.8, that's fantastic and great. If not, we need to do some more things. First step is always discussing with the patient, concordant with lifestyle advice or aware of things that they could do, as well as things we can do, such as prescribing medicines. It's really important to make sure people are taking their statin and that they know that they have to take it at night time as well. Following statins, many people may prefer oral therapies, and ezetimibe is very cost effective and can be used alongside a statin as well. If someone is already optimized on oral therapies, such as statin and ezetimibe, and their cholesterol is still above the target, then we have some more options. If their cholesterol is greater than 3.5 or 4, optionally recommended for them to be referred to secondary care for consideration such as PCSK9 inhibitors. These tend to be given every 2 weeks under the care of the lipidologist, and the target cholesterol is different depending the patient is. So for patients who are very high risk of cardiovascular disease, i.e. they've had or cardiovascular events in more than one vascular bed, um, the recommended cutoff is 3.5. If someone has had one event, then the cutoff is 4. Moving down, we now have a new option available to us in Greater Manchester, which I think is another important tool in our arsenal of medicines that we can use depending on suitability, patient preferences, and that's inclisiran. Inclisiran can be given to anyone with an LDL cholesterol equal to or greater than 2.6 millimoles per liter. Thus, if you've started someone on statins and they've tried ezetimibe or they prefer not to have another oral therapy, you've repeated their cholesterol, it's greater than 1.8 and it comes out at 3, and you can then offer them inclisiran as another option. If at any point patients have a triglyceride level more than 20 once or more than 10 millimoles per liter twice, we can refer those patients to the lipid clinics. Some of that information is down here in this box. All the lipidologists are happy to receive advice and guidance and to support ones with complex cases or people with multiple morbidities, and that's across Greater Manchester. The green box contains some of the information we spoke about the different cutoffs specifically for referral to secondary care and consideration of PCSK9 inhibitors. And finally, the orange box details a quite an important and fantastic advancement in how we are measuring LDL cholesterol. While everyone across Greater Manchester will get an LDL cholesterol from non-fasting blood tests, this tends to be a calculated LDL. And wherever you are across Greater Manchester, you're allowed to use non-fasting cholesterols and calculated LDLs to determine suitability for injectables or other therapies. However, if patients' calculated LDLs are within 0.2 millimoles of the treatment cutoff, then it's advised that we repeat on a fasting sample, as that patient may then be eligible for some therapy that they previously were not eligible for. This is not true for anyone working in primary care who are served by the labs at the Manchester Foundation Trust, as they have just moved to a new direct, and thus no one needs to be fasted in terms of determining their suitability for lipid modifying therapy for the secondary prevention of cardiovascular disease.
And I want to talk a little bit about statins and statin intolerance. As you can imagine, it's a big source of referral to our lipid clinics. So, the first thing is to talk about statin role in lipid management. And this is from national guidance. And for patients who have got already proven cardiovascular disease, we're trying to use the high intensity statins. So that is atorvastatin in doses of 40 milligrams and above, or rosuvastatin in doses of 10 milligrams or above. Simvastatin is no longer recommended at the highest dose because there is an increased risk of muscle toxicity. What you can also see, so you can see that we're getting a reduction somewhere between 40 and 50% with the higher intensity statins, but you can actually see that ezetimibe added to atorvastatin leads to a further reduction. So around about 10% further reduction in cholesterol. So all patients with cardiovascular disease should be offered high intensive statins, and most or many will need a combination of medicines to achieve the target, and we can see that on a slide coming up. And of course, it goes really without saying that all of this has to be in conjunction with dietary and lifestyle advice. So statin intolerance. There are various definitions. One of them is the presence of clinically significant adverse effects that represent an unacceptable risk to the patient or reduce compliance with therapy. Or another definition with any adverse event that's considered unacceptable by the patients or associated with laboratory abnormalities such as raised creatine kinase or abnormal ALT that can be attributed to statin treatment and leading to its discontinuation. Statin-associated muscle symptoms are one of the principal reasons for statin non-adherence or discontinuation. However, not all symptoms should lead to a label of statin intolerance, as they may not truly be statin-related muscle toxicity, as you demonstrate by D-challenge and recurrence with re-challenge. And there is a very recent study that was published in The Lancet by the Cholesterol Collaboration Trialist study that's reported that more than 90% of reported muscle symptoms are actually not due to statins. So non-statin related musculoskeletal symptoms are common, but they should slightly different symptoms, so typically asymmetric, failure to resolve with D-challenge despite a normal creatine kinase, and we're looking at other musculoskeletal disorders, metabolic disorders, and degenerative or inflammatory conditions. Other common things are in vitamin D deficiency and polymyalgia. And it may be prudent in these patients, or you haven't got an obvious reason, to check a bone profile, vitamin D, and CRP. So this is from the statin intolerance pathway that's been published by NHS England. And most of the patients that we see are in these top two groups, so labeled category 0 or 1. So the first category have no symptoms, and they may or may not have a mildly increased CK, but definitely less than fourfold. Many patients have tolerable myalgia, and they don't have any CK elevation. The next most frequent group is the patients with intolerable myalgia who respond to stopping treatment and symptoms recur on rechallenge, but the creatine kinase is usually only mildly elevated, less than fourfold. The other groups with significant CK elevations are much more unusual, and we see rarely in clinic, although they're much more likely to come to us in secondary care. And rhabdomyolysis is very rare now, but they may have massive elevations in CK, sometimes up to 50-fold, and very, very rarely autoimmune mediated necrotizing myositis, which is due to antibodies to the HMG-CoA reductase enzyme. And this is detected on muscle biopsy, but I've personally only seen one case. So the statin intolerance pathway, it's there again in NHS England, but I'm not going to take you through in a lot of detail. But the first thing is to consider other potential side effects for statins. So be aware of the nocebo effect. So statins can have a lot of negative press in the national press, and so patients may be statin reluctant to start with. Consider whether there are obvious causes such as PMR, vitamin D deficiency. And if there's tolerable symptoms and no clinical concern, you may consider continue treatment or stop treatment, see whether the symptoms resolve, check the creatine kinase. And then if the symptoms resolve and the CK is normalized, if the CK was elevated, then we're into seeing whether the patient will accept a rechallenge. You may try a different statin. So if they've been intolerant of atorvastatin, you may either decide to try rosuvastatin or to go back to atorvastatin at a lower dose if they've previously tolerated, for example, 20 milligrams of atorvastatin. If they get a recurrence of symptoms, then at this point, you're into looking at whether other treatment options. And one of the first options that we're thinking about is whether we could add in treatment with ezetimibe, particularly if they can tolerate a lower dose of statin. And if we're still not effective, then we're looking at other treatments, which I'll go through shortly. This side, where we've got very marked increases in creatine kinase, are unusual and would usually be involved in secondary care after treatment stopped with the statin. I want to move now to talk about additional lipid-lowering therapies. And it's been a really exciting area to work in, as we've had quite a number of new therapies available in the last few years. So, divide them up into mechanisms of action. So we've got drugs that reduce hepatic cholesterol, So ezetimibe and the bile acid sequestrants, cholestyramine, cholesavolone and cholestyramine, reduce cholesterol uptake and therefore reduce hepatic cholesterol. The bile acid sequestrants are virtually never used as a new initiated therapy, although there are occasional patients in the clinic who are still prescribed them because they've been taking them for many years. We now also have bempedoic acid, which works on the cholesterol production pathway in the same way, similar way to statins, but it has a different enzyme and it reduces cholesterol synthesis. The other two drugs that we have available, or two groups of drugs, are effective in reducing uptake of LDL cholesterol by changing the LDL cholesterol receptor recycling so that you get more effective LDL cholesterol receptor. And there are two main groups of drugs here, the PCSK9 inhibitors, which are monoclonal antibodies. So there's two available, alirocumab and evolocumab, and they inhibit the breakdown of the LDL receptor through inhibition of PCSK9 enzyme. The other group of treatments are using small interfering RNAs, which again work through PCSK9. So the drug here is inclisiran, and it works through gene silencing. So very exciting technology. So let's look at how effective these different lipid-lowering treatments are. So here's our high-intensity statins, and we should be expecting at least a 40% reduction in LDL cholesterol and sometimes in excess of 50%. As I say, one of the big problems is, or perceived problems of the patients are statin muscle-related symptoms. They can be, and they are contraindicated in severe hepatic and renal impairment at high intensity. Ezetimibe can have at best a 24% reduction in LDL cholesterol. They can have problems with patients with gallstones, particularly if they're co-prescribed with fibrates, and in hepatic impairment. But you can see that the combination of high-intensity statins and ezetimibe is very effective, and we can get over a 60% reduction in LDL cholesterol. We'll move on now to the newer treatments. So bempedoic acid gives you about a 28% reduction in LDL cholesterol. It can cause gout in patients who've got hyperuricemia, and it has been associated with anemia, and it possibly could give it increased exposure to lower intensity statins. It's recommended for use in addition to patients with ezetimibe who are unable to take statins. And you can see that the combination of bempedoic acid and ezetimibe can lead to around a 40% reduction in LDL cholesterol. We now go to the PCSK9 inhibitors, alirocumab and evolocumab. They're given as twice weekly subcutaneous injections, and we can get over a 60% reduction in LDL cholesterol. There's no known interactions to date, and there's still being monitored for hepatic and renal safety. So let's talk about optimizing lipid treatment in cardiovascular disease. So the first thing is using high intensity statins. We want to increase the use of ezetimibe, and GPs have said to me, well, what's the evidence for ezetimibe? Well, there has been a recent trial, the RACING trial, published in The Lancet this year, which showed that rosuvastatin 10 milligrams, so a medium intensity statin with ezetimibe, had the similar outcome to rosuvastatin 20 milligrams in cardiovascular outcome, improved adherence to prescribed treatments, and then if we've still not got an effective LDL cholesterol reduction, using the novel therapies such as PCSK9 inhibitors and inclisiran. This is, as we said before, all in addition to diet and lifestyle. And, you know, in a similar way to hypertension, many patients will need combination therapy if you're to achieve a target of, for argument's sake, less than 1.8 millimoles per litre in LDL cholesterol. So this is a study from published in Atherosclerosis, looking at the percentage of patients on treatment with different drugs and the percentage of those who achieved an LDL cholesterol target of less than 1.8. So, not surprising, the higher intensity statins led to approximately 50% of those, or just under 50% of the patients reaching target, compared to only 19% in those who are on low intensity statins. We gained over 50% achieving target when you combine the statin with ezetimibe. But combination with PCSK9 inhibitor led to the greatest reduction in LDL cholesterol, but was only in a tiny minority. There isn't data on inclisiran in this group. So more than 2/3 of high-risk cardiovascular disease patients are only on low or medium intensity statins as a monotherapy, and we've got only about a third achieving their LDL target. So if we go on to looking at the statins, they're the cornerstone of treatment still, and in addition to LDL cholesterol lowering, are likely to have other effects on anti-inflammatory and plaque stabilizing. Ezetimibe is really useful, particularly in combination with statins, and likely to give a better LDL cholesterol reduction than doubling the dose of statin. So going from 40 to 80 milligrams of atorvastatin is not likely to gain as much LDL cholesterol as 40 milligrams of atorvastatin plus ezetimibe. Bempedoic acid is really is most effective when prescribed in conjunction with ezetimibe. And PCSK9 inhibitors, according to NICE guidance, are only for high-risk cardiovascular patients with cardiovascular disease or familial hypercholesterolemia, and it's a GMMMG red drug. Fibrates are really only used in hypertriglyceridemia because they're not known to significantly reduce cardiovascular risk. And then the novel injectable therapies inclisiran, which I think you're going to hear more about from other speakers. So really, to this audience, don't really need to labor this, but what it's showing is that patients who actually take therapy, so have optimal adherence, have a much lower number of cumulative events than patients who are not adhering to treatment. And there's been calculations that this could equate to 1 MI, stroke, or cardiovascular death prevented every 2 weeks in an average size practice, and would have a very significant effect on outcome. So practical points, lower is better. For instance, in China, the normal LDL cholesterol in the population is less than 1 millimole per litre. And we know that atheroma formation really markedly reduces when the LDL cholesterol is less than 2. and there may be some evidence that you get atheroma regression. Cholesterol does vary from day to day, and there's seasonal changes too, so treating exactly to target is impossible on a single blood test. And in order to effectively reach targets, you need to use effective treatment. When should you refer to secondary care? If there's proven or suspected familial hypercholesterolemia, if there's failure to achieve target on maximum tolerated dose of statin plus or minus ezetimibe and inclisiran where indicated, if the patient is intolerant of statins, and severe hypertriglyceridemia, so by that I mean serum triglycerides of 20 millimoles per litre or 10 millimoles per litre on more than one occasion. Recurrent events on treatment, unexplained cardiovascular events at a young age, or unexplained family history of cardiovascular disease. So that nicely brings us on to talk very briefly about familial hypercholesterolemia. So familial hypercholesterolemia is underdiagnosed, but if it's unrecognized, is life-limiting, but is easily and readily treatable. And it affects 1 in 250 to 1 in 500 of the population. It's autosomal dominant and therefore a 50% chance of passing it on to the next generation. If it's unrecognized and untreated, 50% of patients with familial hypercholesterolemia have a cardiovascular death by the age of 50 and only 50% living until retirement age. But with generic statins and a healthy lifestyle, including not smoking, life expectancy is normal. It's estimated across the UK that we're currently only got 5% of the patients with familial hypercholesterolemia who've been diagnosed. And there's a long-term plan across the NHS to increase this to 25% by 2025. So what criteria do we use? Well, there are Simon Broome criteria, which are based on total cholesterol in an adult of greater than 7.5 millimoles per litre or LDL cholesterol of greater than 4.9, plus, if it's definite, the presence of either tendon xanthometer, which have to be I haven't seen for some years now, or the presence of DNA mutations, which as we're moving through to be able to request genetic testing is becoming more common, or possible familial hypercholesterolemia is based on the same cholesterol targets, i.e. an LDL cholesterol greater than 4.9, but with a family history of myocardial infarction in a first-degree relative below the age of 60 or a second-degree relative below the age of 50. If we come on to the Dutch Lipid Clinic network, I'm not going to go through those in great detail, but they use a points system which actually takes the LDL cholesterol value. So you get 5 points if the LDL cholesterol is above 8.5, for instance, and also uses personal history of cardiovascular disease and not just family history. There's an expanded list of success criteria for the Contract Direct Enhanced Service, and familial hypercholesterolemia is genetic diagnosis, and there are going to be pathways across Greater Manchester to look at improving the diagnosis of familial hypercholesterolemia. Finally, I wanted to briefly touch on hypertriglyceridemia and which patients you need to refer. So the first group are patients who've got a serum triglyceride of more than 20 millimoles per litre. And if you've excluded excess alcohol or poor glycemic control as being a cause, then they need urgent specialist review, and that's because they have a increased risk of developing acute pancreatitis. For triglycerides that are still significantly elevated between 10 and 20 millimoles per litre, the first thing is to repeat the triglyceride measurements with a fasting test. And usually it's recommended that somewhere between 5 and 14 days from the previous sample. And again, review for potential secondary causes, so particularly diabetes and alcohol. And consider referral to secondary care if the repeat triglycerides are above 10. For the vast majority of patients that have a triglycerides above 4.5 but below 10, be aware that cardiovascular risk tools as we currently use them may underestimate risk. And so consider seeking specialist advice if the non-HDL cholesterol is more than 7.5. And for this group, it's been particularly useful that we're able to measure LDL cholesterol by the direct LDL cholesterol across MFT, because that can give us a look into cardiovascular risk.
To help us all with the pathway, we've been working hard to create EMIS searches, System 1 searches, and Vision searches as well. The EMIS searches and the electronic health record searches match exactly the pathway and should hopefully make your life a lot easier. The searches initially find everyone who is in the high risk CVD cohort. So everyone had a stent put in, who's had a stroke or has angina. Or it then looks at their latest cholesterol, and if they've had a cholesterol within the last 12 months, patients who have not had a cholesterol within the last 12 months are within one of the searches. Then everyone who has had a cholesterol within the last 12 months is split according to what type of action or work needs to be done for that patient. And so they specifically for those not on a statin at all, and they should really be contacted and started on a statin such as atorvastatin 80 milligrams. It's got two cohorts for patients on either a suboptimal type of statin or a suboptimal dose of statin, and their cholesterol is still out of target. So if a patient's cholesterol is within target and they're on a suboptimal dose, that's okay and absolutely fine, and they will not come up within these cohorts. Finally, there's cohort 4, and these are the people who the statin has already been optimized. They've had a blood test within the last 12 months, and their LDL or non-HDL is still above target. It's these people, depending on what their last LDL was, that would be eligible for further intervention, such as ezetimibe, inclisiran, or other injectables, and or referral to secondary care, depending on the patient's preference. So thank you for listening to this video. I hope it has given you an insight into why tackling CVD is so important for us in Greater Manchester, while also demonstrating how a relatively simple change in clinical practice could actually have a tangible impact. There's been a lot of work underway centrally to help support you in getting on top of CVD within your population, and any and all feedback is of course welcome.